very esteemed colleagues. Tracy Farrell is a physician assistant and senior instructor in the Division of Hematology here at the University of Colorado. She received her bachelor's degree in chemistry and sociology from Creighton University. She then worked as a research assistant at the University of Nebraska Medical Center, working primarily with basic science cancer research. She received her master's in physician assistant studies at the University of Nebraska Medical Center. Sorry, there's a lot of University of Nebraska in here. I'm so sorry. I got lost. She began her career in malignant hematology as a PA, also at the University of Nebraska. But then we were so fortunate that she decided to move to Colorado, and she has been here for the past 3 years, 4 years? Oh my gosh, 4.5 years. Time flies. She spends all of her spare time being injured in various sports. If you need expertise in an ACL repair, she's your girl, okay? And traveling. I also am excited to introduce Katie Harper. She is one of our registered dietitians with over 19 years of experience working with cancer patients, specializing in blood cancers. She received her bachelor's degree in nutrition sciences at Washington State University, a master's of science in nutrition, and completed a accredited internship through Colorado State University in that as well. She's a certified specialist in oncology and a certified nutrition support clinician, and is the inpatient nutrition support team lead. She has lectured on nutrition and cancer both nationally and internationally, and is an author in the chapter Medical Nutrition Therapy for Hematopoietic Stem Cell Transplantation and Oncology Nutrition for Clinical Practice. So please join me in welcoming them for the next presentation.
Thank you, Meredith. We have a couple different microphones because like we practice very much in tandem in the inpatient setting and outpatient setting, we bounce back and forth a lot in our presentations. So here's a list of our objectives. Essentially, during this time, we hope to present you with a patient case study that kind of walks through the whole transplant. Katie will go over a little bit about identifying risk for malnutrition especially during the transplant setting, and then we'll walk you through some gastrointestinal toxicities, which is maybe a little too close to lunch, so finish up quick. And then we'll kind of talk about how we prevent, identify, and treat those toxicities. We have no disclosures. I'll use some brand names of medications, but they're not paying me to. So here's our case study. This is a 32-year-old male with ALL. They received some traditional induction chemotherapy that I have listed for you there. The end of induction bone marrow biopsy was negative by pathology, but in the send-out, it had some measurable residual disease on NGS testing. So they received blinatumomab and moved straight towards stem cell transplant. Here's a list of their regimen. I made this up based on this patient, so don't look too closely at it. But the real point of it is that they got high intensity myeloablative regimen, including fludarabine, cytarabine, and total body irradiation. I also threw in some of their medications that they got for GVHD prevention.
Is this on? Yeah. Okay. So we're gonna jump into this patient and give you a little background on nutrition if you guys aren't familiar with nutrition during the stem cell transplant process. So this is just an example. This is a little bit outdated now, but AT, our case study, is getting the most toxic and the most intense regimen. And so they're going to be the ones at highest nutrition risk. And then they're going to have the most problems or issues and need a lot of symptom management and symptom care. So when we talk about medical nutrition therapy and transplant, AT saw a dietitian prior to admission. So all of our patients see dietitians prior to admission for transplant. We are consulted on admission. So they see a dietitian within 72 hours of admission, and then they are followed very closely both inpatient and out. So all transplant patients who are receiving an allo transplant are at risk for malnutrition, especially if they're getting a myeloablative or reduced intensity regimen. And they will all require nutrition support. Nutrition support includes both nutrition counseling, oral nutrition supplements, dietary interventions. It may include enteral nutrition, and it may include parenteral nutrition. With AT, we identified that he's very high risk, so he will be receiving enteral nutrition or tube feeds during his transplant. So the nutrition intervention should be a very integral part of the transplant treatment plan. And the dietitian should provide a very personalized nutrition plan that aims at preventing or reducing malnutrition in this population. So the first thing we typically start with is the nutrition counseling and oral nutrition supplements. If a patient is identified at high risk, we may go straight to tube feeding. And then parenteral nutrition is something that we try to avoid in our stem cell transplant patients because there are a lot of complications and risks. And I'll talk a little bit about that now. So that would be our kind of our last intervention if they failed enteral or could not get a feeding tube placed. And our overall goal is to prevent malnutrition. So when we look at best practice recommendations for enteral nutrition and transplant, I just highlighted a few. So ESPN, the European Society, and the American Society for Parenteral and Enteral Nutrition recommend enteral nutrition as first line of support in a transplant unless there is a contraindication. When we look at a meta-analysis, Zamal et al., they recommended, after looking at the literature, there should be prompt increased effort to implement enteral nutrition as first-line nutrition support because the reduced rates of acute GVHD and acute GVHD grade 3 to 4 that they found. And Beckhold et al. Looked at when enteral nutrition should be indicated, and his recommendation is it should be considered standard of care for all transplant patients for the benefits to survival, quicker engraftment, and reduced GVHD. So I bring all this up as a background because we'll be talking about it through his transplant process, AT's transplant process. So here at UC Health, we have come up with prophylactic feeding tube indications. So someone who will get or knows they're getting a tube at day +1 to day +3. So anybody with a BMI less than 20, anybody with any protein calorie malnutrition diagnosed pre-transplant. It's highlighted in red. So AT, the myeloablative conditioning. So we know up front he's not going to do well and not going to get his nutrition. And so he's going to get a feeding tube placed. Anybody with a history of previous transplants, heavily treated, a lot of comorbidities or a lot of comorbidities such as like gastroparesis or a lot of GI issues, we know they're also going to struggle. And then if they don't meet criteria for a feeding tube, that dietitian is going to monitor that patient and see if they meet criteria during their transplant. So if they're not able to meet their needs orally and it's expected to greater than 5 days before engraftment, we're going to want to place a tube in that patient. If they become malnourished during transplant, the first sign of mucositis, we want to put a tube in. And then if the RD just identifies this patient as really struggling or anticipates they're going to struggle. So these are our current guidelines at our facility. So why does this matter? Why does nutrition matter? Why do we want to prevent malnutrition in these patients? There's a lot of reasons. Malnutrition during transplant increases morbidity and mortality. It increases their time to neutrophil engraftment. It increases their readmission rates, their length of stay, so they have to stay longer, which patients aren't too happy about. Risk of just immunological and infectious complications. Their body just doesn't have the fuel to fight off stuff. Severity and number of treatment side effects. So that mucositis is going to last longer. It's going to take longer to heal if they don't have nutrition. It increases the GVHD risk as well. And so all of these combined is why we really want to focus on how do we get in good nutrition, how do we control their symptoms so we can feed them and get them good nutrition throughout their transplant. And so that's what we'll be talking about today as we dive a little bit more into symptom management.
Perfect. So we'll go into a little bit of GI toxicities overall and how we approach them from a symptom management standpoint, and then how we also integrate our dietary colleagues into the treatment and kind of risk factors for these different toxicities. So when I think about mucositis, I'm thinking about the whole GI tract actually. So a lot of times we think about it in just the mouth and the throat, but this is affecting the whole GI tract. And so anything that kind of interrupts that mucosal lining, I would consider as mucositis. So this is our case study with our patient. On day +2, he starts to complain of his mouth being a little painful. It's getting a little sore to swallow things, but definitely still eating and drinking okay. On day 4, it's like when he's starting to develop painful sores, mostly on the bottom of his tongue. It's getting harder to have solid foods, okay to eat shakes. It's okay to swallow liquids. And then some of his meds are becoming a little painful, especially some of the bigger ones. And then day 6 is when he's reporting pain that's like really limiting from eating much. And then he's really can only take medications. He has to take them very slowly. It's extremely painful, maybe taking some pain meds before taking these medications. And so some risk factors that were involved in this patient and other patients, some patient-related factors, and then conditioning-related factors. So patient-related factors is a poor nutritional status going into stem cell transplant. You're at much higher risk of developing mucositis, poor oral hygiene prior to transplant, poor oral hygiene during transplant, and then any like dental appliances. So people with dentures, and then anyone who's been smoking recently or younger age is more likely to develop mucositis during their transplant. With this patient specifically, we're looking at the regimen-related factors. So he had total body irradiation. He's having this very intense myeloablative conditioning. The way I explain it to patients a lot of times is we're trying to destroy all these rapidly dividing cells that include the bone marrow, but that also includes the rapidly dividing cells that line your mouth, that line your gut, that line your stomach, and all your intestines. And so a lot of that is also kind of disrupted when we're giving these people extremely high-intensity chemotherapy regimens. So the World Health Organization kind of makes a scale of mucositis from 0 to 4. We don't usually use this, but it is interesting from a data collection standpoint. Probably 80 to 90% of people develop any cause of mucositis during their transplant. And I think it's close to 50 to 60% that's doing grade 3 or more. And so these people are really not able to tolerate any solid food or medications. Oh, sorry, I should have told you pictures. Don't look if you don't want to. Some examples of mucositis. Yeah, I should have given you a jump scare warning here. So some pictures of mucositis. It's painful. It's bad. I explain it to people. It's like a sunburn inside your mouth. It's just so painful. A lot of breakdown of that mucosa. So when we look at the clinical course, it can usually be around a week after starting chemotherapy, which for a lot of patients is day +1, day 0, day +1. So that's why when we work with our dietary colleagues, we think about when is the right time to start to think about placing those feeding tubes and to start enteral nutrition is like right before you start getting any of these mouth sores. So moderate to severe mucositis in a lot of these patients, longer hospitalization, delayed neutrophil engraftment, GI-related infections. This breakdown of the skin barrier also allows for bacteria to translocate. And so now we're talking about infections in the mouth. And so at the end of the page is when we're talking about neutrophil engraftment, and that's when these mouth sores start to heal up. From a treatment standpoint, it's not a lot. It's kind of like a sunburn. You just got to wait it out. You wait for the new skin to grow back and kind of treat the pain and treat risk of infection in the short term. And so in a lot of places, including a lot of children's hospitals and other stem cell transplant centers, they're using this low-level laser therapy to help prevent and to treat mucositis to help decrease how long it lasts. But a lot of it, what we're doing right now is oral care. So we're doing baking soda and salt mouth rinses to kind of help keep the mouth clean and prevent infection. A lot of just gentle brushing to keep things clean, and then just pain control. So, lidocaine mouthwashes to make things numb before you eat or take medications. Oral pain meds when they can take them, if it isn't too painful to start them, and then IV pain meds when it's needed. And then I'll let Katie tell you a little bit about the nutritional support and how we interact that with mucositis.
So after each time Tracy gives a little bit of the symptom management, I will give kind of the nutrition review interventions we think about or we do. Some of these are pretty obvious, and a patient, comes up with them themselves. They're not going to eat that chip anymore because it really hurt going down. So it's really soft, moist foods. We talk about adding sauces, fat, anything that coats their mouth that helps things slide down. Avoiding those really dry foods or crunchy foods that it's going to be really painful to go down that throat. We also do a lot of medication review with the APP, with the pharmacist. How can we help this patient? Can we get their meds scheduled before meals? Can we do more mucositis mouthwash? Those types of things. So I do a lot of review with the team on kind of managing symptoms through that way. And then if it's really painful, I actually tell patients it is okay to not eat, because if they're eating 2 bites of Jell-O and getting 10 calories from that Jell-O, and that's having them push their PCA button, it's really not worth those 20 calories because it's causing so much and so severe increase of pain. Now we have a backup. We have enteral nutrition running. So if you don't have a backup, then that you're not going to want to tell patients that, or you should probably be starting nutrition support anyways, because they will not be getting in enough nutrition. So I will rely 100% on nutrition support in these PCA mucositis type regimens. Like this patient got the 12 gray. I knew right off the bat that's, mainly PCA mucositis is what I call it when I teach people, because we know it's going to get really bad and he's not going to be able to meet his needs. And so that's why we identify patients really early on. So that outpatient dietitian looks at that patient's regimen and says, oh, they're getting a myeloablative regimen. You're going to be getting a feeding tube during transplant. We know already you're not going to meet your needs. And so they are prepped. Psychology also talks to them about it. So our whole team tries to really prep them so it's never a surprise. Our goal is to place it to day +1 to day +3. They may not have mucositis starting at that point, but we know it's coming. So sometimes it's hard to convince a patient that we know what's coming. And they are still eating when we place these tubes, and they can continue to eat until they can't anymore. So it's a really huge collaboration, and it's been a learning point, and still is a learning point with our team. We started in 2018 placing feeding tubes, and we've learned a lot along the way. But placing it early, you're going to get much more successful tube placements. And then a patient maybe who didn't meet that criteria up front for a feeding tube, the APPs or rounding, I round daily with the team. The minute I hear someone saying, ooh, my mouth's a little sensitive or things are hurting a little bit more, we're going to want to place a tube that day, because you may miss that safe window to place a tube, and it is too painful or too risky to place it in someone with severe mucositis as you think about something going down when it's very irritated. And so we want to identify these patients up front, or we miss the window to be able to use the feeding tube and place it. So back to our case study, Tracy already kind of talked about when his mucositis started. He was aware of the feeding tube, so he knew it was coming. He knew what day it was coming. So on day +2, the team ordered the feeding tube placement, which is in our window at our facility to try to make these tubes more comfortable to place. Unfortunately, we cannot knock patients out, which they request all the time, a little Versed or something. They need to be able to swallow that tube. So we have come up with an order set. We think of it as our tube feed comfort medication order set. And so we are going to give them anti-anxiety medications that helps the gag reflux, that helps their anxiety around a tube placement. We're going to provide them with pain medications. We're going to provide them with an antiemetic if they need one. And we're going to give them a numbing throat liquid for their throat. And we also give them Eurojet in their nose. And then we also do like a vasoconstrictor spray to reduce the risk of nosebleeds. So as soon as we order this tube, there is an order set that comes with this for comfort. And then platelet counts need to be equal or greater than 20 for safe placement. And that's based on some very limited literature. And so we make sure, the whole team makes sure that on the day we're placing the tube, the platelets are equal or greater than 20. If they are not, then we give them platelets and then we will place the feeding tube. And then we will initiate enteral nutrition based on their oral intake. So he was still eating a little bit, so we did a cycle overnight, and then he would eat during the day. And that's what we started with since he was still eating.
Perfect. So we've moved on a little bit. Now we're talking a little bit about chemotherapy-induced nausea and vomiting, which is a big part of a lot of patients' experience during their cancer treatment, especially during a stem cell transplant. A lot of it can be irritation from mucositis too that's causing this nausea and then just vomiting reflex from it. And this is where you're glad I didn't bring pictures for all sections. You're welcome. So for this patient, his nausea is well controlled for the first few days. It normally is. He gets a couple days of chemotherapy. They're doing great. They're walking around, they're eating, they're having a great time. Day -2, he starts to complain of a little nausea with his meals. Takes some PRNs, a little either like Zofran or Compazine right before his meals, and is doing okay. Day -1, he gets his total body irradiation and has a lot of MSS afterwards. So some risk factors, which are pretty similar to those same risk factors as there are for mucositis. But if they have a lot of nausea and vomiting with their induction chemotherapy or chemotherapy before, they're a little bit more at risk of getting nausea and vomiting with their transplant chemotherapy. And then a lot of anxiety makes you a little more likely to have some nausea and vomiting with your chemotherapy. With your transplant or conditioning regimen, like this patient, I think it's on this slide here. So the more intense your regimen is, the more likely you're going to have nausea and vomiting during. So we expect these people to have nausea and vomiting. 90+%, 100% of people will have nausea and vomiting during their allo stem cell transplant. This is something we see and do all the time. So from a clinical course standpoint, it usually can start to begin with the initiation of chemotherapy. In my experience, it will take a few days to get kind of this massive chemotherapy in you and really start to hit effect. So usually kind of right around that transplant time as you're starting to get some nausea and vomiting. This acute phase, which is like during your conditioning chemotherapy and then the week after transplant, is probably the most intense phase of nausea and vomiting during that time. But it can last for up to 30 days after transplant. So it's kind of persistent. Every patient's a little different. I'm sure Katie can try to predict which patients will have this like prolonged nausea and vomiting, but it's very hard to predict. Some people just have it longer than others. And so when I think about treatment, this is kind of a busy slide, but I think about classes of medications for the most part when I'm thinking about treatment for nausea and vomiting. So we have some things that we use to prevent chemotherapy-induced nausea and vomiting, like ondansetron, olanzapine, and then Amend or aprepitant. So we're using some things to prevent it, but when I'm thinking about treating someone with nausea and vomiting, I'm thinking about pulling one thing from each of these categories. And so it doesn't do any good, and some of the toxicities build up if I use 3 things from one category. But what I'm trying to do is look at your Zofran and then Compazine if you need it, and then add an anticholinergic like your promethazine or your Benadryl, in addition to Ativan, which is a different point. So we're kind of pulling things from each of these categories and hoping that we're treating all of these receptors that are targeted by these nausea and vomiting treatments. I'm pretty anti-cholinergic. I guess I'm pro-cholinergic at this point, where I'm not a big fan of a scopolamine patch, but it just depends on what's causing your nausea and then how to treat it. So if you're getting up and walking around and you're getting dizzy and having nausea because you're moving, that's the right place for a scopolamine patch. A lot of these have a lot of side effects. So every nausea med we give causes more things to happen. And so it's more figuring out what's actually going on with the patient, what things we want to avoid from a side effect profile, and then trying to pick things that will help with their nausea and vomiting through the course.
So when I speak to these patients, initially some of the dietary changes can help, but this is such strong treatment with the TBI and the chemotherapy. Diet alone will not control their nausea. And so like Tracy said, they often have to do multiple layers of antiemetics to be able to get them to eat, keep them eating, or be able to tolerate their tube feeds. And so when I see a patient, I'm going to review all their medications. And it seems that patients often confess to me maybe a little bit more than their APPs. Well, I'm not eating, so I don't have nausea. Or if I don't move and I don't eat, I don't have nausea. Or my stomach feels a little weird when I see my meal. So sometimes they think they have to be vomiting to have nausea. And we can't have them not eating at all because, that's important as well. And so I'm going to review, are they using PRNs? Some patients, are going to use meds and some patients are never going to ask for that PRN. And so do we need to schedule more antiemetics? Do we need to encourage the nurse to give them more PRNs or change more and layer on the antiemetics? Because we don't want them vomiting the whole way through. Small frequent meals are going to stretch or trigger those receptors less. And so as Tracy said, we're trying to block those receptors with a lot of these antiemetics. If you do smaller meals, you're going to trigger those receptors less. And that's why small frequent meals often work with nausea. And then oral nutrition supplements. So a patient will often get nauseated when their meal comes in, but when their small little protein complex, or compact protein drink comes in, that's a little more tolerable to them. And they can sip on that over an hour and get 500 calories versus taking 2 bites of toast. So that's why we use a lot of oral nutrition supplements. And then if this patient is on enteral nutrition, that's the time for the dietitian to review. If they are not tolerating because they're having nausea and we've maximized the antiemetics, then I may need to change my formula. At UCH, we use a whole food formula. So it's real food blended. So it's a bright orange, but it has a lot of fiber in it. And so sometimes that load of fiber becomes too big for that patient and it's going to be slow to clear from their stomach. So we will change to a peptide based or a broken down amino acid based enteral nutrition formula without a huge load. And then we want to make sure we're not making a super or having a super concentrated formula. And so we usually do like a 1.5 cal per milliliter. We may need to slow that rate down. So if a patient is on cycle and we're trying to get a ton of nutrition overnight, we may need to do a 24/7 cycle or 24/7 infusion, and the rate is going to be a lot slower. And then, yeah, again, if they're on a cycle, we may need to, it might be the time to go to continuous. And then we want to review medications. A lot of times the patient's like, when I take my meds orally, I get really sick. So is this the time we need to talk to the APPs and pharmacists about changing to IV medications? Sometimes putting them down the tube because they're swallowing the medications makes them nauseated. And then we also want to think about if this is an acute change, they were doing okay yesterday, tube feeds, nausea was controlled, and now all of a sudden we're having significant nausea, vomiting. Has that tube migrated? Has that tube flipped up? And so we may need to image that tube. We may also consider going post-pyloric or through the stomach opening to get better tolerance rather than feeding them into their stomach. So these are the things when we assess, we look at. So as Tracy alluded to, his nausea was worse on day +6. So I changed him from that cycle overnight feed to a slower rate, and I provided 100% of nutrition needs. We added more scheduled antiemetics on and made sure the nurse or the patient was asking for those PRN antiemetics. And he continued to have controlled but a stable low-level nausea without vomiting day +8 through his engraftment time.
Perfect. So we're going to talk a little bit about anorexia. I think we think about anorexia as like decreased food intake, decreased appetite in the setting where there's no structural abnormality. So there's no gastroparesis, there's no bowel obstruction, they're just not wanting to eat. This is kind of a challenging subject for us and our patients because a lot of times people just don't want to eat. And there's some things we can do about it, and there's a lot of things we can't do about it. So this patient, during their conditioning regimen, they developed their mucositis. They developed nausea and vomiting day -2, day -1, right? And so day +2, their intake is limited by their mucositis pain. And then day +6, this intake is limited by all this nausea they were having. And so that's why we are trying to adjust their tube feeds. And so when we think about anorexia, I'm thinking about what is causing this patient to not eat. And a lot of it is this symptom management that we've already talked about with these other symptoms. So is it the mucositis that's contributing? Is it the nausea and vomiting that's contributing? There's other things that could cause it. So medications can cause a lack of appetite. Infections can cause a lack of appetite. And there's a lot of psychological factors. I think that's probably a whole different discussion for Maria later. There's a lot of psychological factors that go into not wanting to eat or not feeling like they're able to eat during a transplant. And so what we're trying to do while working with our dietary colleagues is figure out what is causing them to not want to eat and then try to help in any way we can. In this short-term setting, appetite stimulants are not really overly helpful. A lot of times it's just trying to put a Band-Aid on something, but it's adding one more medication to their bucket that they're taking 3 times a day and isn't super helpful in the short term while we have these 18 other factors that we're trying to control for.
So yeah, anorexia is a really hard one to deal with. The biggest thing, I don't want patients to feel guilty for not eating. I always tell them you have so many barriers. 90% of patients aren't able to eat enough. And so I really want them to not feel that guilt. That is one of the nice things when you have a feeding tube is you can take that pressure off. That caregiver feels comfortable. That patient is getting their nutrition and they don't have to continually force themselves to eat and vomit and feel worse when they're eating because they have a continuous supply of nutrition. So we will work with them and we will try to eliminate or decrease any of those barriers. Sometimes it's that plastic, dome they get, and you open that thing. If you guys have ever opened those, like the whoosh of smell that you get from that, even when you haven't had chemo, is very intense. And so I have them open that outside the room. I have the nurse dissipate that smell into the hallway, not into the patient's room. So there are little things we can do. And then, they can bring food from home. We actually encourage it as long as they follow, our immunocompromised food safety guidelines, because I know they're going to eat better if they get their crackers that they like and their peanut butter that they like and the things that they like. And so we try to eliminate any barriers we can, but most of the time we can't eliminate all of those. And that's where that feeding tube is helpful. Again, the oral nutrition supplements. And then if we have tried everything and this patient doesn't have a feeding tube, if they're continuing not to be able to meet their needs, that's when we would want to place that feeding tube. So back to our patient. He was still a little hungry, but the barrier to eating was more the mucositis and the nausea. And so we were trying to maximize those and still keep him eating as long as we could. The tube feeds were meeting 50% of his needs in that 12-hour cycle. And day 6 is when that pain became too bad, and his nausea was worsening, so he was unable to get enough in. And so at that point, tube feeds were increased to 24 hours a day and 100% of his needs. And then they continued that until he engrafted, because we know appetite's not going to get better until their cells come.
Okay, perfect. Now raise your hand if you're really glad I didn't bring pictures for every section here. So we're moving into diarrhea. It's essentially like mucositis of your intestines that's causing you to have a lot of diarrhea post-transplant. So everyone put your food away and we'll get going. So this patient, tied with all of their other toxicities, day -1, that's when this patient was starting to have their nausea. They started to have mucositis around this time frame. Now, unfortunately, they were worried about constipation, especially ondansetron or Zofran can cause a lot of constipation in the short term. They're not eating their normal food. They're not walking around as much. A lot of these patients are actually constipated when they come in the door, and they're begging for things to make them less constipated. But we know what's going to happen. And what's going to happen is day +3, they're starting to have maybe 1 or 2 loose stools a day. Your definition of diarrhea can differ maybe, but we kind of use what the patients say is diarrhea. We're calling that diarrhea. Day 7, now they're having 3+ loose stools a day of just diarrhea. And so thankfully we didn't treat their constipation a week ago. So risk factors, there's a lot of medications that can cause diarrhea, unfortunately, and it's all things we're giving the patient as part of their normal transplant process. So their conditioning regimen, especially their total body irradiation, all this chemotherapy we're giving them is kind of just destroying all that gut lining. Antibiotics, we're messing with the gut microbiome and they're causing a lot of diarrhea. Immunosuppressive therapy, especially oral medications, can cause a lot of diarrhea. And then medication suspended in solution is something I learned from Katie. So, they're having all this mucositis, so we're switching them to, a liquid solution of acyclovir for their preventative medication. This is like mixing dextrose or some sort of glucose-based, solution. Sorbitol.
Like sugar alcohol.
Goes straight through you. So these people, we're trying to prevent their mucositis and give them their medications orally. We're just causing them to have more diarrhea. Microbiome dysbiosis caused by all these antibiotics, chemotherapy, and then higher levels of immunosuppression. So the differential for diarrhea during a transplant process is, its own presentation, but we are thinking a lot about infections. So these people are profoundly immunocompromised for the 2 weeks post-transplant. And so we're trying to make sure that we're not missing things by just blaming it on the chemotherapy. I like to blame everything on the chemotherapy, but I think, we can say they could have a viral infection like CMV or norovirus. They could have a bacterial infection like C. difficile. They could have a parasitic ones, although that's a lot less common in our patient population. So the conditioning regimen is the toxic chemotherapy that they're getting that can cause it. And then things that my friend Katie has to think about that I don't usually, which is like lactose intolerance, pancreatic dysfunction, all that can cause diarrhea that is not something that we think about. We're like, it's the chemotherapy, it's the chemotherapy. There's a lot more that goes into it. And then engraftment syndrome, we'll talk a little bit about at the end, but graft versus host disease also. So these are all like later transplant things that you have to keep in mind of like juggling all these balls of what could cause diarrhea in a post-transplant setting. So when I'm thinking about diarrhea, I'm like, what could be causing it? Here's the 18 things that could cause it, making sure you're ruling out all those things and the kind of dangerous things or things that you want to make sure you don't miss in the short term. And so we're trying to rule out C. diff colitis before we're giving them Imodium or something to stop their stools because we're trying to prevent toxic megacolon. And so that's kind of the big don't miss this in the setting of diarrhea post-transplant that we're trying to figure out. And then if they're having a lot of pain, if they're having fevers, we're going to try to get a CAT scan of their abdomen and make sure we're not missing a neutropenic enterocolitis, that antibiotics, IV antibiotics could help treat their diarrhea in that short term as well. And so treatment is similar. We're identifying those things, removing any contributing factors to their diarrhea, and then we're going to give them Imodium. And so we're going to start slow. I tell people don't take it. Everyone wants to take it with every loose stool they have. They're going to go the other way. We're going to cause an ileus. So take 1 dose, take 2 doses in a day and kind of see where the stools go from there. We can go up to 16 milligrams of Imodium a day, which is a lot. It's 4 milligrams 4 times. And then we can add on maybe some more things that we don't use as often, like Lomotil, tincture of opium. And then they're also going to need IV fluid support. So they're losing all of this fluid through their stool. And so we're just trying to make sure that we're not causing any issues with fluid balance.
So nutrition review of diarrhea. So we will look at their antidiarrheal medication usage. We have a great tab in Epic that I use. And if they only got 4 milligrams, that's probably not enough for them if they're still having 6 or 8 stools a day. And so I will review that with the APPs. I will be the one sometimes in rounds be like, hey, they only got 4. We can go up to 16. We've given them 25% dose. It's not going to touch their diarrhea. We need to be able to slow this down so we can keep up with lights, we can keep up with nutrition, we can keep up with fluids, and then adding additional agents once we max out on Imodium and other things. For diet, low insoluble fiber. So there's 2 different types of fiber. Usually we group them all together, but we think of insoluble fiber as roughage, as salads, as wheat bread, brown rice. That's going to really irritate their gut and push things through faster. Soluble fiber, on the other hand, is things like oatmeal, banana, white rice. If you've ever made oatmeal, which has a little bit of insoluble too, and not put enough water in it, it turns to cement. We want that to happen in their gut. We want it to absorb all that volume so they get a little more bulk and a little more form to their stools. And so we will encourage them to have soluble fiber foods and discourage them to have insoluble fiber foods. Then we will encourage low lactose foods. So when you get treatment and we have mucositis and we irritate the gut lining, you become temporary lactose intolerant. Now, if you had already lactose intolerance before, this is going to make it worse. If you didn't have much, then you've developed a lactose intolerance until your gut can heal. So most of these patients cannot tolerate a lot of lactose foods. And so I would counsel them on, we have lactose-free milk, we have almond milk, we have soy milk. So if they're just doing it in their cereal, they're probably okay with that. If they like to drink a lot of milk, then I don't want to take that source of nutrition away from them, and we will start lactase enzymes like Lactaid. So we do some counseling with that. But again, if that's a big load of their calories, then I try to give them something like a lactase enzyme that'll help them break that down. And then we adjust their tube feed formula. All tube feed formulas are lactose free. So we never take the lactose free out of formula because it's never there. Are we doing that high fiber whole food formula? Sometimes that's just too much because it has both insoluble and soluble. So I will switch to fiber free formula, and then I will give fiber outside of the tube. So a soluble fiber outside of the feeding tube I will add on. We will slow their rate down. Maybe that rate is too fast for them, so I need to slow it down. And again, if they're on a cycle, then I would change them then to continuous. And then I'm going to review the medications. Tracy stole my thunder a little bit here. So if you ask a dietitian, an inpatient dietitian, the med they hate the most that comes in liquid, it's Tylenol. Liquid Tylenol is going to cause them to have gas. It's going to have them diarrhea. It's really one of the #1 offending ones that we see throughout the ICU and in our patients. And so can we give that a different way? A lot of times tube feeds get blamed for diarrhea. And the reason is it's usually their gut is getting worse. So their mucositis is starting to build. And then we change all the medications to liquid. And if you guys are old enough to know or have seen this around, sugar-free gummy bears and the Amazon reviews, they were full of sorbitol. And so all the symptoms those people had and all those reviews they gave, which if you haven't seen it, it's pretty funny, it's because they had large doses of sorbitol. So it caused gas, bloating, and a lot of diarrhea. And that's what these liquid medications. So I work with the APPs and the pharmacists. Can we do something else? Can we switch to IV? Because that's really irritating their already really mad gut. Magnesium oral, most people know that one. Antibiotics, PPI, some of the other stuff that we have to give, but are there different forms or things that they can tolerate? If stool is consistently greater than a liter and we're maximizing stuff, then we need to think of parenteral nutrition. So it's not that we never use parenteral nutrition at our facility, but we really use it as our last resort and not our first. And I don't have enough time to talk about all the complications and risks of parenteral nutrition. That's a whole separate talk that I would happy to give someone else. But so we may need to switch to parenteral because they need a source of nutrition and they're showed we can't absorb. We may need to reduce that tube feed till we get better control, or may need to hold it all together. So they're not going to be absorbing if they're having consistently greater than a liter a day. So back to our case study, day 7, his mucositis of his gut was worsening. He had been tolerating that enteral nutrition since day +2. The day before we changed it to 24 hours due to lack of PO. So I adjusted his formula to a semi-elemental or a peptide base, so easier to digest. And I removed the whole food formula to decrease the fiber. And then I added separate modulars that the nurses were giving of soluble fiber through the tube to absorb that fluid, increase that bulk, and slow down that diarrhea.
Perfect. So now we're at the end of this guy's transplant course. We've gone through a lot of the problems they've had starting day -2 through this time frame of all this stool, day +6, day +8. So he's been in the hospital for a while. Day +18, he starts to feel a little better, right? So his white count starts to come up. He starts to feel a little bit better. Everything's somewhat improving. So his intake's slowly improving. He still has the Dobhoffen, but he can eat a little bit more. He's got reduced pain in his throat, a little fewer mouth sores. His diarrhea is persisting, but it's stable to improving. But on day 19, he has a fever and his diarrhea gets a little bit worse. So we're kind of, I'll let you talk, sorry, too.
It's not a people table. So
yeah, we didn't make a table. But we, yeah, go ahead.
So engraftment's starting to happen. So what I tell patients is, this is how I picture it. We're going to hurt your gut with a conditioning regimen. We put a lot of Band-Aids on because your gut is not going to heal until you engraft. And so those Band-Aids are all those symptom management medications, all the other things we do. And until their GI tract starts to heal as they engraft, those Band-Aids are going to remain in place and things are not going to get better. But as soon as they start engrafting, that's when that turnover can happen. That GI tract actually has a quick turnover. And so the mucositis will heal if we have the building blocks. If we have good nutrition throughout, then they will be able to heal. It's not going to speed things up, but lack of nutrition will definitely slow stuff down. So they start to eat better because they're feeling a little better. Their symptoms are starting to improve. Their mucositis pain is starting to improve. And so we're going to start thinking about weaning from enteral nutrition and removing that feeding tube. Then, like Tracy said, engraftment can cause a very acute increase in diarrhea. And so when I see that they're engrafting, their cells are coming up and there's this big increase in diarrhea, they may recheck C. diff or something else. And what I'm going to do is maybe slow down the tube feed for a day or so. But that engraftment and that engraftment diarrhea resolves very quickly. So I don't want to be very alarmist and change or stop tube feeds completely if I know this is likely going to get better in a day or two. So our patient preparing for discharge, we remove the feeding tube. So at some point when we've engrafted and things are starting to heal, that feeding tube becomes a barrier. It is hard to swallow oral pills with that feeding tube, and we need to get him out and he needs to be able to swallow his pills. And so when I think that tube is more of a barrier than a benefit, then I'm going to want to remove it even if they're not eating great. And we know, or hopefully this patient has received 100% of his estimated nutrition needs throughout transplant. So if it takes them a few days to really get going on eating, I'm not as worried as someone who got no nutrition, who is already malnourished, and then they're going to keep on going. So we pull them out a little bit earlier than probably any other dietitian would in the hospital, different patients. And then at our facility, we are very grateful. We have 3 or 4 BMT specific dietitians. And so they are scheduled to see the dietitian within a week of discharge. So I feel a little safer letting the patient go, if I know they're going to be seen pretty quickly and there can be more troubleshooting outpatient. And then I also know as soon as that patient walks out the hospital, because they're not getting hospital food, they're not stuck in their bed, they're doing much better, they're going to eat better. 25% better. They have their home food. They know what salt they put on it. They know what is coming up, if it's a green banana or a yellow banana, so I know the minute they walk out of the door, 25% probably increase in oral intake. So we know it's likely to get better. If it doesn't and it's prolonged, things we need to think about, some of their medications. This is the time we may think about an appetite stimulant where we're getting more into the chronic phase. Or do we need to think about or talk to the physician? This patient's losing weight, they're having anorexia, nausea is worsening. Some of the dietitians will be like, could this be GVHD? Do we need to think about that? Because upper GVHD is harder to diagnose because it's just like lack of poor appetite, a little bit of nausea sometimes. And so that's the other thing we want to think about. If they're starting to have an increase in their symptoms when they were already better, maybe we're moving into the GVHD phase of things. I have time. Okay, we put this in for fun. So again, I could talk about this subject, my colleagues probably know. So why is it important? Why do we want to do enteral nutrition? Why do we want to keep these people fed through their gut? This is a really exciting field. It's really new. There's still not a lot known about it, but the microbiota is huge, and we really transplant, just kills that. I mean, we fry them. We give them antibiotics. I mean, we wipe it out. So one of the ways to help support that microbiota is feeding it. So how do we feed it? We feed it orally or enterally. And so that can help give a trophic effect on the enterocyte. So it feeds it nutrients when you feed the gut. And those, you produce short chain fatty acids, and that's really beneficial to the patient. Now, if we just did parental nutrition and we did not feed this patient, then we are causing a whole host of things, and we are adding into the issue that we've already created by killing everything off. And so Tracy talked about this a little bit. There's going to be translocation and increased risk of bacteremias. We're not using that muscle, and so it's going to atrophy. It's going to be harder to get back to eating. It's going to be harder to heal. And so there's a huge negative effect of not feeding the gut throughout the whole transplant. And again, this is really new research and exciting, hard to study research, but I think it's a huge thing in this field. I just liked this cartoon picture, feeding the gut. That's why we use a whole food formula. That's why, there's carrots and all sorts of good things in the formula that we use for tube feeding. We're helping those short chain fatty acids and all the host of things that is below that, intestinal immune homeostasis, repair and restoration of the gut, pathogen clearance. The gut and the microbiota do a whole host of things, and we want to support that the best we can. And one of those ways is enteral oral nutrition, and there's some good studies on that. This is like way over my kind of knowledge, but I love this picture. So blue is and sorry, it's really busy. Blue is beneficial associations with certain type of bacterial species. And red is the negative. So when they look at the use of parental nutrition during transplant, they find a greater abundance of Enterococcus and proteobacteria, which is mainly the red things. So you can see mainly on the left side, all the complications that happens when we have an increased number of those in the microbiota. Decreased overall survival, increased VIR bloodstream infections, increased mortality. So there's huge effects this has downstream, and there'll be much more research on this coming up. And then enteral nutrition is associated with those short chain fatty acids and more of the blue, the really beneficial things, by having more beneficial gut bacterial species. So increased overall survival, reduced GVHD, which is so hard to treat, as we know, and so bad when patients get it. So if we can do anything to decrease their risk, using the gut the whole way through transplant is super beneficial. So I won't read through all of this. I just thought it was a really cool, really good visual of all the negative effects of having more of that type of bacterial and all the positive effects by eating and feeding the gut. So we will end on that and see what questions we have. We also have all of our references listed, and I am happy to talk about this subject at any time.
Thank you. You guys can see why we're very lucky to have Katie and her dietary colleagues working with us on a day-to-day basis with these patients, because this is way above and beyond things that I can comprehend. I'm like here to put Band-Aids on things, and Katie's thinking 3 steps ahead. So I'm very happy to have her and work with her. We have time for questions and a short break, maybe, if there's no questions. Yeah, Alex.
Sorry. So Katie, I feel like historically, and admittedly, it's been a while since I've worked inpatient, but historically, getting buy-in to place a tube in somebody who doesn't yet feel bad is a very hard thing to do. And I feel like there's probably ways and strategies you have to approach this conversation in an earlier phase of things to know that that discussion might be coming even if you yet don't feel bad. Can you speak to that a little bit?
Yeah, we've been doing this since 2018. I think I've wanted to quit about 20 times. But I'm very passionate about this, obviously. It takes buy-in from the whole team. You can have one person say, "Oh, I would not do that tube," and that patient is out. And so we want them to know before they walk in the door to get their transplant, they are getting a tube, they're getting it on this day, and it's for this reason. So it has taken a lot of education. So I will get in front of anybody I can get in front of, and I will talk about the benefits, because I also want the team to know why we're doing it, because it does make things a little bit harder, and so I want that patient to understand, because that patient doesn't understand, there's not going to have buy-in. We also have our psychology team talk about it during the intake for transplant. And they can also help if that patient is nervous about that tube. They can come and help and work with them on techniques for acceptance of that tube. We've also got the comfort package that I like to call it. And so, yes, I have to sell these tubes a lot. If I don't have backup from the team, these patients would not agree. I am also on rounds every day, and I go in with the doctor every day, and they have come on board, and they will support it as well. They will say, yes, our plan is to get a feeding tube, and this is why. So you need buy-in, and the more research we have, the more buy-in we're going to get. And so I am trying to get into more of the physician journals and write articles and talk more at physician talks, so I can get the leaders, because the dietitians, they know we want a tube. So we got to get everybody else to buy in. So I would say education is your number one thing to get buy-in from the physicians, your team, and the patients.
From an APP standpoint, the day they're admitted, when I'm talking to them about stuff, I was like, the dietitian will see you in the next few days, and we're going to start to talk about what things cause nausea and what things cause low appetite and malnutrition, in order to make sure that we're setting it up for success the next day. When Katie walks in the door, they're like, oh, I heard it 3 weeks ago that I was getting a tube, but I also heard it when I got here. And then I heard it the day after and the day after. And then Katie walks in and they're like, oh, yes, we know about this. We're, familiar with this. So it does take a lot of different people saying the same thing to kind of like reinforce that point.
We had some issues with the head and neck patients not created. And we can have, I don't know what you doing right that patient is good. So not it's don't want to.
Yeah, I really want them to know it's not because of failure. right? That the patient, there are a lot of barriers. So I just do a lot of education and again, having the whole team. If that doctor says this is the plan, you're getting a tube on, this is part of your treatment plan, it is built in, you get a lot less refusal rather than it being more optional. Now, we get refusals. I mean, we do. So there are going to be that patient who said, no way, no how, you are not touching my nose. But I also find that they actually don't know what a tube is. They don't know it goes in their nose. They think it goes in their mouth and they can't talk and they can't eat and they can't move. And so there is also, I try to figure out the why they're very hesitant about it. We also bring in our psychology team and they sometimes can help us figure out the why. Sometimes they're like, well, I had a tube before and it was huge. Well, they had a decompressive, huge NG tube and we put in small. So there's, trying to figure out the why, but you're always going to get refusals. And hopefully you have a dietitian colleague and someone who can really speak and talk the literature, in a patient level. But yeah, you're always going to have, we are not perfect by any means. I might've oversold myself a little bit. Yeah. I will say from when we started to where we are now, the agreement is much, much higher. It was very poor before, but now we have a much better team approach. They know it's coming. They know the day it's coming. They know other patients and they see other patients walking around with it. So yeah, but head and neck is also a very challenging population. So yeah, but you're always going to get patient refusal.
Any other questions?
I have a question. I think I think we're doing a really great job at taking care of these patients, when they come in for transplant. But I guess my question is, are there opportunities to do a better job before they come into transplant? So, a patient gets diagnosed with acute myeloid leukemia, they go through aza-ven or 7+3 induction chemotherapy, maybe a couple, 2-3 months before they get to the transplant. And during that whole period of time, we're becoming more and more nutritionally depleted in a lot of cases. So is there benefit in looking at these patients when we say, okay, you're a transplant candidate, we're going to start looking for donors? Is that the time to put more effort into working on their nutrition and other things? I mean, I think it kind of spans the kind of breadths of what we do, probably nutrition, physical rehab, psychological support, all of these things. But I'm just curious what you guys think, if there's more opportunities in the nutrition side of things before transplant.
Yeah, I mean, I think there's always more opportunities everywhere, right? But yeah, there are studies showing that more dietitians can, visits and pre-transplant can prevent that malnutrition. So that patient is well nourished coming in, they're going to do better. They're not malnourished coming in and then at risk for further malnutrition. So there are good studies looking at very early on interventions. Our clinic is pretty well supported with dietitians. And so they are there, they can be consulted at any time, and they should be seeing, I don't know if this is actually true, but new AML diagnoses because we know what's happening, or those really high diagnoses, pancreatic cancer and other things in our cancer center, those patients are seen, first time of chemo and they're followed through. So early intervention is always better because it's very hard to reverse malnutrition once it's there. And once they're malnourished, their outcome is going to be worse. So I think, and prehab and all the other stuff that comes with that, setting them up for better success rather than being so beat up when they arrive for transplant.
Okay. Previously worked at an institution that did not have a great coordination with dietitians, so I'm super jealous post. But we did, the one thing that they did do that they were able to get through was we tested vitamin D. Have you guys seen that research, and do you do that in your facility?
Yeah,
Because
so
the difference in GVHD was like amazing to me, and I was so shocked.
Yeah, I mean, it's across a lot of the blood cancers, but we check vitamin D in all of our patients pre-transplant, not only for benefit survival, also 50% of patients have bone disease 1 year post-transplant. And so also for bone health. But there, yeah, are a lot of studies looking at D. So we do supplement all the way throughout. I typically do the 50,000 once a week because it's 6 less pills. And so the more I can, because I'm inpatient. But yeah, the dietitian will address that pre-transplant, start them supplementing. We'll continue it inpatient if they can tolerate oral, and then they'll reassess about 3 months or so after, and then at their like 90-day, and then I think at their year survival, we'll be following that D all the way through.
I was trying to get our department to work with dietitian. We were trying to get through, and I had a patient who had a vitamin D of like 4 and had the worst GVHD and mucositis. And it just made me, even thinking about it now, like I'm like, we just tortured this man. And I like at that point, that was the hill I died on. But we're one of the ones, but still, it's really cool to see that you guys have taken it even further than that.
Yeah, and with GVHD, it's also a fat-soluble vitamin, so they often have a lot of fat-soluble deficiencies, A, E, and D. So if D is that low, they're probably malabsorbing, and then there might be some pancreatic insufficiency on top of GVHD. So those are things we kind of think about more in the chronic setting as they're getting further along. But yeah, we do a lot of vitamin mineral assessments. In the acute setting, they're not as accurate. So we're a little cautious with interpretation, but D is something we really check. And then the others, if there's an indication.
Mm-hmm. Awesome. That's our time, unless anyone has anything pressing. So thank you so much.
Thank you.
All right, great job, you guys. It was the APP provider, dietitian collaboration and transplant patients is certainly one of the most important things that we do.